you so much for our panelists for being here. We really appreciate your time. So we have here Dr. Vidya Prakash, who is a professor of clinical internal medicine, Department of Medicine, and the member of the infectious disease faculty. Thank you so much for being here today. We have Dr. Vidya Sundareshan, who is also an infectious disease specialist and has received her medical degree from Dr. B.R. Ambedkar Medical College. We are delighted to have you today as well. And then we have Dr. Korala, who's joining us, who got his medical degree from Tribhuvan University Institute of Medicine. So thank you all so much for being here this morning. We greatly appreciate your time. And thank you to all the attendees. What we can do is have the chat available for any questions, and we can take them along the way. We'd like to have an interactive discussion towards the end. So feel free to unmute yourselves. And if you'd like to ask questions as well, the chat box is open, so we can go ahead and get started.
Thank you so much, Molly. And many thanks to Dr. Rahani and the entire Health for the World team for inviting us to be here. It truly is an honor and a privilege to be here with you and talk about such an important topic. I'm going to go ahead and share my screen, and I will introduce the rest of our panelists. Please let me know if you're able to see my slides. Okay. So as Molly and Dr. Rahani said, my name is Dr. Vidya Prakash. I am a professor and infectious diseases faculty at Southern Illinois University School of Medicine. I'm joined by my friend and colleague, Dr. Vidya Sundareshan, who is also a professor, infectious diseases faculty and division chief at Southern Illinois University School of Medicine of infectious disease. Dr. Daniel O'Keefe, who is an infectious diseases fellow at our institution. And I'm especially delighted to introduce Dr. Janak Karala, who is an emeritus professor and also leading the pandemic efforts in Nepal. And we are delighted to welcome him and have him share his input as well. We're here to talk about mucormycosis in patients with COVID-19. So without further ado, I would like to start with a case to set a framework for our conversation today. This is a case report in the literature of a 60-year-old male who was diabetic, on oral medications, who presented with the chief complaint of dyspnea, fever, and malaise. On presentation, his vital signs were as follows. He had no fever, his heart rate was 80, blood pressure was 150/90, respiratory rate 26, and his PCR was positive for COVID-19. And you see his chest CT on the right, which showed these multifocal patchy ground glass opacities in the bilateral upper lobes, the right middle lobe, the lingula, predominantly in a peripheral distribution, strongly suggestive of COVID-19. The patient was started on broad spectrum antibiotics with intravenous meropenem, IV oseltamivir, and corticosteroids, and for his diabetes on sliding scale insulin. The patient unfortunately developed progressive respiratory distress requiring non-invasive positive pressure ventilation. When it looked like it was apparent that he was in cytokine storm, he was started on an IL-6 inhibitor on hospital day 4 with tocilizumab. And for his diabetes, his regimen was intensified with long-acting insulin with glargine, as well as metformin to maintain strict glycemic control. On hospital day 10, he had bilateral lid edema with right eye prominence. And for that reason, he was transferred to a higher level of care, and with the preliminary diagnosis of right orbital cellulitis. Now, interestingly, his hemoglobin was 10.4. His creatinine was elevated at 1.57. His C-reactive protein was elevated at 29, with the normal being less than 5. And his D dimer and IL-6 levels were both elevated at 1,547 and 3,439 respectively. An ophthalmologic consultation was requested the next day, and on exam, the right eye was mildly proptotic with extensive areas of edema in the periorbital region with soft tissue necrosis along the medial half of the upper and lower lids. He had congestion of the right eye with conjunctival edema and signs of exposure keratitis. The left eye appeared fixed and dilated, either due to extension of infection or COVID-19 coagulopathy. An MRI was done, and you see that this was an axial MRI on the left, which shows hyperintensity in the ethmoid and nasal sinus and of the retrobulbar space. And in particular, the coronal section, T1, showed irregular hyperintensity of the retrobulbar space. This was highly suggestive of mucormycosis. And so the patient was immediately started on amphotericin, in addition to broadening antibiotics to vancomycin and meropenem. And they did a biopsy that was consistent with mucormycosis with filamentous fungi suggestive of mucor and confirmed with Savarro's dextrose agar culture. Despite aggressive measures, the patient continued to deteriorate, was hypotensive, which is why they were not able to take him expeditiously to the OR for debridement. And despite all those measures, he died. So what does this case beg? It begs a lot of questions. The main ones being, what were his risk factors prior to the hospitalization, during the hospitalization? What were some measures to have made the diagnosis of mucormycosis clinically more quickly and in a more expedited manner? And what is the appropriate treatment, and what are good preventive measures? So today we'll be covering epidemiology and the current situation in India. We'll discuss the description and pathogenesis of mucormycosis. We'll discuss clinical presentation and treatment, some cases, and we'll talk a little bit about the situation in Nepal, and that will be done specifically by Dr. Kerala. I will hand it over to my colleague, Dr. Vidya Sundaresan, who will start talking about epidemiology and the current situation. Dr. Sundaresan.
Thank you, Dr. Prakash, and thank you again to Dr. Rihani for this great opportunity to be able to speak to a wide audience. And I really want to take this opportunity also to thank Health for the World for the fantastic work that you're doing. Dr. Prakash and I have had the good fortune of being part of some of the communications, and it's just amazing the work that you're doing. So with that, I will start out with a short definition of mucormycosis, previously also referred to as zygomycosis. It is a serious but a rare fungal infection. Just a one-line definition, it is a ubiquitous and a thermotolerant fungus which is caused by a mold, the group being known as Mucormycetes. So with that one-line definition, we're going to be elaborating more on that in subsequent slides. Want to say that the risk is different in different populations, so it's variable. We don't really have good data as to what the clear incidence is. And now with COVID-19, that surveillance has somewhat changed. But prior to that, we have information from San Francisco Bay Area, where a population-based incidence estimate was done based on some laboratory surveillance, and suggested that the incidence could be about 1.7 cases per million population, so not very common. And they also looked specifically in the transplant recipients, about 16,000 recipients in another study between 2001 and 2006. And about 8% of all the invasive fungal infections found in this population were accounted for by mucor. Similarly, in solid organ transplant recipients, 2% of all invasive fungal infections were mucor. So we can say that it's about 2 to 8% of all the invasive fungal infections in patients with transplant, which is a group that they have studied. Next slide, please. So reviewing that again, in the transplant population, one of the studies looked at 929 cases and delineated some of the top risk factors to see what the breakdown was. About 36% of the cases reported with mucor were found in diabetics. About 17% had hematologic cancers, and about 12% had solid organ or hematopoietic cell transplantation, a history of these. So these are some of the top 3 risk factors that we are mentioning, but there are also others which I would be talking about. Next slide, please. So we have also really gotten some information about mucor from outbreaks. There's really no it's not a reportable disease. So there's really no registry that CDC maintains or anybody else maintains in terms of, what the exact numbers are. But there is some information on outbreaks. And with regards to outbreaks, the information in healthcare associated mucormycosis comes from infections related to adhesive bandages, wooden tongue depressors, hospital linen, negative pressure rooms, water leaks, poor air filtration. All these are some of the causes where outbreaks for mucormycosis have been reported. There's also been community onset outbreaks with natural disasters. We in Springfield have actually had experience of one such natural disaster causing a slew of mucormycosis cases. So I'll talk about that in a while as well. Next slide, please. So another parameter that we looked at the incidence, we looked at what kind of breakdown we find with the risk factors, and diabetics being the top one there. We look at also the mortality from this. This is a severe infection and in many times life-threatening. So the overall all-cause mortality is estimated to be about 54%. And this is not from the latest data. This is again from data in 2001 to 2006. The overall cause mortality is about 56%. 46% of those ended up having sinus infections, 76% with pulmonary infections, and 96% mortality for those with disseminated mucormycosis. So this is overall a bad infection with poor outcomes despite treatment. Next slide, please. So now coming to some of the local data, this is a report, actually communication from Lancet as of 3rd of June, which reported about 14,872 cases as of May 28th in India. The state of Gujarat alone had about 3,726 cases. And some of the other states have also started to report. So the top 2 were Gujarat and Maharashtra. Since May 19th, about 90 deaths attributed to mucormycosis. And then, and most of these were, the patients were either with uncontrolled diabetes, excessive use of corticosteroids, or long-term stay in the ICU, which were reported in this communication. Next slide, please. Some of the other states where we have also seen the numbers rise are Rajasthan, Andhra Pradesh, Karnataka, Haryana, Madhya Pradesh, Uttarakhand, and Delhi, where mucor have also steadily seen a rise in their numbers and deaths related to mucormycosis. And one thing nice about the way this is handled currently is that it is recognized as an outbreak, it is recognized as an epidemic, and it is being reported. So we have better data now. We have more information on the true prevalence, and we're able to estimate the numbers with respect to mortality and also with respect to treatment, how that has been given for these patients with the information that is currently available, as compared to even CDC's information in the past, where mucormycosis is really not a reportable condition in the United States. So the first wave of, could you go back to the previous slide, please? Thank you. So the first wave of COVID did see mucormycosis, but the second wave seems to have more. I also want to mention that even prior to COVID-19 in India, there were actually a number of cases of mucormycosis were going up, and the reason for that is not really very clear, but they do think that the soil or even the weather, and also undiagnosed cases of diabetes with advanced diabetes could be some of the reasons why the numbers were going up even prior to COVID-19. And just a word about amphotericin B. This is the drug of choice, but clearly a huge shortage of that. 0.1 million vials of amphotericin B were already used. This kind of tells you the extent to which the disease is prevalent. But again, even this seems to have fallen short. Next slide, please. So I'll quickly go over the risk factors and the numbers from the risk factors which would be relevant for EPI. And these will be discussed more in detail in the pathogenesis part as well for the presentation. We did talk about malignancy and cell transplantation, hematopoietic cell transplantation. About 17% of those with mucor having these risk factors. But if you look at the total number of people undergoing transplantation and total number of people with malignancy, it accounts to about 0.1 to 2%, the average being about 1% or so of this population. One important aspect there has been a graft versus host disease, patients with graft versus host disease, or also people who were using voriconazole as prophylaxis or treatment. That was an independent risk factor with an odds ratio of about 10.4, 95% confidence interval being 2.1 to 39 there. Next slide, please. With solid organ transplantation, again, similar numbers, less than 1%. And again, risk factors included prior antifungal use, azoles like voriconazole, and also caspofungin or micafungin, echinocandin. The use of these in patients with immunocompromising conditions is quite common, and that in itself can be a predisposing factor for solid organ transplants. A special mention there to renal transplantation patients who seem to have an enhanced risk. Next slide, please. Diabetes, if you look at the graph and the dark blue being diabetes, multiple studies will show you that in fact is one of the biggest proportions there for mucormycosis as a risk factor. And one point that I would like to make here is in the United States, we have seen a decline in the number of patients with diabetes and that group. And statins, the widespread use of statins, which may have an inhibitory activity in vitro against mucor, has been attributed for this. Next slide, please. Healthcare associated, we talked about contaminated tongue blades or instruments during surgery where the mucor could be introduced at the surgical sites. A lot of these infections with healthcare associated end up being cutaneous or GI tract. So, those are the two important organ systems which could be affected by the healthcare, and we did discuss about how they could be introduced. Next slide, please. So natural disasters. We did have a tornado here in Missouri, close by, very close to where we practice in Springfield. And we did have a lot of patients come in with skin lesions. And again, this is very similar with natural disasters. People have injuries, so there could be multiple skin portals where the environmental fungus could get introduced via and cause infections. People who had blunt trauma, people who had fractures were also noted to have a risk for infections in addition to the penetrating trauma wounds that was seen. And they did look at that, and the whole genome sequencing identified as apophysomyces, one of the types which was specifically found with this natural disaster in Missouri, where a tornado was implicated. Next slide, please. We've also seen this in military personnel who sustained blast injuries and coming back after combat in Afghanistan, where again, the soil is rich in this. This is a ubiquitous fungus. You find this a lot in the environment, and anytime there is contamination, there is risk again for these infections, mucor being one of them. There were other fungal infections too, but mucor was also found in a large number of patients who did sustain wounds and blast injuries in combat as well. Next slide, please. So again, this is a comparison of the different organ systems presenting with mucor. You can have the rhino-orbital cerebral mucormycosis, pulmonary, cutaneous, renal, different manifestations. Just want to show here that the rhino-orbital cerebral kind of leads the pack there in terms of the presentations. On your right is the global data. On your left are a meta-analysis and data from India. And again, the rhino orbital cellular mucormycosis is high. The one in the pink, the bar is pretty tall there. Next slide, please. Again, the type of organism, Dr. Prakash is going to talk more about this, but Rhizopus, if you want to remember one, this is a big group, but that is one organism where the number in dark blue there is very high in most of the studies. And I'd like to mention a word about outcomes and treatments. The treatment is amphotericin B and surgery, and this figure there on the right kind of compares amphotericin B with surgery or amphotericin B alone or surgery alone. The outcomes are much better in the combination, where the mortality rate you'll see is lowest there. Next slide, please. So word about COVID-19 related mucor. I just want to bring up 2 points that people being admitted could have the presentations a few weeks after they have been diagnosed with COVID-19, or they could also present simultaneously with COVID-19. So we're seeing both those. So, you know, implicating this as a cause is difficult. With this temporality and the way these patients are presenting. So a lot of thought has gone into it, and Dr. Prakash will allude to that in the pathogenesis aspect as well. Gastric mucormycosis, a couple of cases have been found, and one case, especially with treatment with steroids and IL-6 inhibitor, much like the case that Dr. Prakash had presented, different presentation, but gastric mucormycosis was reported in a patient with a similar treatment regimen. And then pre-existing diabetes and use of glucocorticoids together seems to be found in most of these patients. And the mortality data that's coming out of reports from India is about overall mortality of about 31%. Next slide, please. ICMR has excellent guidelines. I just use this slide as a segue to the next part of the presentation, which is going to be on pathogenesis. And I will hand it back to Dr. Prakash.
Thank you so much for that excellent review, Dr. Sundaresan. As you just mentioned, I'm going to move on to description and pathogenesis. There is a lot of terminology floating around about these infections. So up until 2 decades ago, we started with kingdom fungi, and zygomycetes was the term used collectively for infections due to Mucorales and due to Entophthorales. However, now we've had reclassification. So now we still have, under the kingdom of fungi, we have phylum Glomeromycota. So essentially the term zygomycetes or zygomycota is a thing of the past. We don't use that term anymore. The subphyla that we're using now are Mucorales, Entomopterales, Kixales, and Zoopagomycotina. It's a mouthful, but that is our most recent classification. And this slide gives you another visual where I've really highlighted what we formerly saw as zygomycetes or zygomycota are now more specifically referred to as Mucormycotina or Entomoptermycotina. And infections or diseases due to these classes are collectively known as Mucorales and Entomopterales. When you look at clinically relevant infections due to these subphyla, when you look at, I'm going to start with the Entomopterales. We have genus Basidiobulus and Conidiobolus. And interestingly, this subphyla and the infections under it really occur more in tropical and subtropical regions, typically in otherwise healthy hosts, and usually cause chronic subcutaneous indolent infections. And this is to be distinguished from the subphylum Mucormycotina, which the diseases collectively are known as mucormycoses. And in that, we have multiple genuses, of which Dr. Sundaresan highlighted one of the most common, which is Rhizopus, along with Rhizomucor, Succinea, Mucor, formerly Obsidia, now known as Lictimea, Cunninghamella, and Epaphosomyces. So these are collectively the genuses associated with infections due to the subphylum Mucormycotina. And as I said, unlike the other subphylum, these infections characteristically occur in profoundly immunosuppressed patients and cause rapidly progressive severe disease, as we're going to discuss shortly. And these microbes under Mucormycotina are much more ubiquitous. As Dr. Sundaresan said, they're found worldwide. They're common saprobes on decaying organic material, agricultural and forest soils, and rapidly growing and characterized by large ribbon-like hyphae with no or only few septae. So let's talk about what's actually happening at the molecular level. This is a depiction of interactions of Mucorales with endothelial cells during hematogenous dissemination or organ seeding. So I'm going to bring your attention to box A here. And so you see the epithelial cells, the tissue, and the endothelial cells. So in box A, you have iron bound to transferrin. And what happens, the initial patient that I presented, who was a diabetic, commonly in patients with diabetes, and particularly those who present in diabetic ketoacidosis, because of the hyperglycemic state and the acidic environment, you have liberation of iron from the transferrin. And we know that free iron helps to propagate growth of the pathogen. In B, you see ketones in the form of beta hydroxybutyrate that we see in diabetic ketoacidosis and the free iron. In addition to propagating the growth of the Mucorales, they also blunt the immune response. So it's another hit to the host in that the immune system is not able to do its job. Now, one mitigating factor is the addition of sodium bicarbonate. Sodium bicarbonate not only reduces the likelihood that iron is going to be liberated from transferrin, but it also neutralizes the acidic environment. So that is something that's beneficial. I'm going to draw your attention to box C here that shows upregulated surface expression of this protein called glucose regulator protein, or GRP78. And it's known that upregulation of this protein also enhances endothelial damage and angioinvasion. Moving on to box C, where we have the actual pathogen, and this big gray circle here is the Mucormycosis germling. We talked about how liberation of free iron, glucose, and beta hydroxybutyrate propagate the growth of the pathogen. But in addition, iron and beta hydroxybutyrate in particular upregulate COT-H on the surface of the pathogen. And again, that helps it attach and invade. It helps it with angioinvasion. Finally, in box E, in your deferoxamine treated patients, which is a risk factor, iron-rich ferrioxamine binds to its receptors on the surface of the pathogen, the receptors being FOB1 and FOB2. That in turn liberates the iron so that it just re-enters the cell to the FTR1 receptor, which again propagates the growth. So a lot going on here at the cellular level, but it's important for us to keep that in mind when we're thinking of prevention and especially treatment. When you're looking at patients on the clinical level, you know, especially for orbital mucormycosis that Dr. Sundaresan talked about, it starts with inhalation of the fungal spores in the environment. And remember, mucorales and mucormycosis, it's ubiquitous. Those spores are trapped in the paranasal sinuses. And from there, you have colonization, blockage of your macrophages, and relative deficiency of neutrophils and hyperglycemia. And as we talked about in the previous slide, during this process, remember, the hyperglycemia and the acidic environment leads to liberation of iron, beta hydroxybutyrate, and all of those, in addition to the hyperglycemia, again, propagate growth of the virus and help with endothelial invasion. So then you have fungal proliferation along with this iron overload. That invasion leads to necrosis, which further blunts the immune response, and then you have rapid spread of the infection to the orbit. Dr. Sundaresan went in details about the risk factors. Putting those in context, remember, we talked about high glucose, acidic medium, and decreased phagocytic activity of white blood cells. So immunosuppression, especially in the form of corticosteroids and IL-6 inhibitors, make this environment ripe for this pathogen. The acidic medium brought on by metabolic acidosis, particularly in patients in diabetic ketoacidosis. Having pre-existing diabetes and steroid-induced hyperglycemia leads to this high glucose environment. And invariably, our patients with COVID who are hospitalized are hypoxic, and that low oxygen environment is good for the pathogen too. Diabetes is at the top of the list of pre-existing factors and risk factors. And Dr. Sundaresan talked about a lot of these already: short and long-term corticosteroid use, malignancy, organ transplant recipients, those with prolonged neutropenia, iron overload or hemochromatosis, those with severe burns, HIV/AIDS patients, malnourished, and open wounds following trauma. I would like to review this recent systematic review of cases reported worldwide and in particular in India that was published in May of 2021. And I want to call your attention to a couple of things. First, we're seeing that mucormycosis in the setting of COVID-19 was more common in males. So of the 101 cases reported, 78.9% occurred in males. And hyperglycemia at presentation, whether it was due to pre-existing diabetes or new onset hyperglycemia or new onset diabetic ketoacidosis, was the single most important risk factor for developing mucormyces. Steroid use, so a majority of the patients, 76.3%, were on steroids, followed by 20% on remdesivir and 4% on IL-6 inhibitor, tocilizumab. And most common clinical presentation was nasal and sinus, followed by rhino-orbital presentation, although this occurred along a continuum and there was considerable overlap. Interestingly, it was the DKA patients that classically presented with rhino-orbital cerebral mucormycosis. Pulmonary involvement tended to occur more in patients who were had prolonged neutropenia, were heme patients, heme malignancy patient, or patients or organ transplant recipients. And GI mucor tended to occur more in malnourished patients. And as Dr. Sundaresan said, mortality was 30.7%. I like this diagram because it puts it all in context. So when you look at it most simply, COVID-19 elicits an acute hyperglycemic state, oftentimes brought on by corticosteroids. And that, in addition to new onset hyperglycemia or pre-existing hyperglycemia, makes the environment primed for diabetic ketoacidosis, resulting in mucormycosis. When you look at the other risks around this, in particular with corticosteroids and pre-existing diabetes, we already talked about the pathogenesis, especially behind the pre-existing diabetes. We also talked about how COVID-19 leads to hypoxemia. It also leads to lymphopenia, endothelitis, which then upregulates that endothelial receptor glucose regulated protein that we talked about, and upregulates COT-H on the surface of the pathogen, which again leads to mucormycosis. COVID-19 also causes a relative cytokine storm, which again increases ferritin, increases intracellular free iron, and therefore propagates mucormycosis. And we've also talked about metabolic acidosis with the acidic environment really helping to make this a ripe medium for mucormycosis. And that in turn also affects upregulation of COT-H and GRP78. I am going to hand it over to Dr. O'Keefe to talk about clinical presentation and treatment.
Thank you, Dr. Prakash. Good morning, everyone. Thank you for your attention. I'll just like to take a few minutes to talk about the clinical presentation of mucormycosis. The two focus areas I'd like to talk about is the syndrome that's called rhino-orbital cerebral mucormycosis, as well as pulmonary mucormycosis. But as Dr. Sundaresan and Dr. Prakash alluded to previously, these are not the only clinical presentations. It can involve the skin as well as the GI tract, and it is a rapidly progressive disease and can disseminate to other organs of the body, such as the lungs, the abdominal organs. Now, with regards to rhino-orbital cerebral mucormycosis, or ROCM, it is the most commonly cited clinical presentation. It can refer to an entire spectrum that's ranging from just sinonasal disease, rhino-orbital disease, or even the full-blown spectrum, which is rhino-orbital cerebral disease with involvement extending to the CNS. Next slide, Dr. Prakash. With regards to this syndrome, patients usually in the outpatient setting usually can present with signs and symptoms of suggestive acute sinusitis or inflammation of the sinuses. They commonly complain of nasal congestion or obstruction, sinus pain, but most clinical scenarios that I reviewed, they also can pertain to what is best to be described as purulent nasal discharge, or it's characteristically brown, black, or they can even report bloody noses, or on undergoing endoscopic examination can look like dried blood. There's soft paranasal swelling. Patient's history, commonly they have prolonged history of fever, headache, And with the progression of the disease extending into other organs or adjacent spaces, they can report tooth pain, jaw pain, and if the fifth cranial nerve begins to be involved, they can report facial pain, paresthesias, or even numbness. Now, all sinuses can become involved, and it can spread to contiguous structures such as the palate, the orbit, and the brain, and again, it can progress rapidly. Next slide, Dr. Prakash. And with regards to eye involvement, patients will often present with a history of blurred or double vision, decreased visual acuities on formal exam, the proptosis of the eyelid, proptosis of the eyeball, or complete ophthalmoplegia, as well as periorbital edema, and ultimately the complication of concern would be blindness. Next slide. Now, well, the hallmarks of this syndrome is that it can spread to adjacent structures, such as can involve the palate, leading to tissue necrosis, leading to the characteristic formation of eschar on the hard palate. It can lead to destruction of the nasal terminates, as well as paranasal swelling, erythema, and cyanosis of the facial skin, as well as overlying skin involving the sinuses and the orbit. With regards to pulmonary mucormycosis, patients commonly present with a history of fever, cough, shortness of breath, chest pain, as well as sputum production that can involve hemoptysis. Now, it's again a rapidly progressive disease. It can lead to acute hypoxic respiratory failure requiring intubation, as well as further spread to other organs such as the mediastinum and the heart. Now, as Dr. Prakash and Dr. Sundaresan alluded to, treatment of this syndrome is more often than not multifactorial. Initially, it involves surgical debridement as in combination with antifungal therapy, but attention must also be turned to elimination of predisposing factors for the infection, such as hyperglycemia in patients with a history of diabetes or who are currently undergoing therapy with steroids or steroid-induced hyperglycemia, patients that are suffering from metabolic acidosis such as DKA or as a result of significant infection or sepsis, as well as, if possible, the elimination of immunosuppressive drugs such as the reduction of steroids, etc. With regards to surgery treatment, aggressive surgical debridement, if able, is end of the involved tissues is a strong recommendation by all the panels that have provided recommendations. Now, this can serve as treatment in a number of ways. Number one, it can result in the removal of necrotic tissue and debulking of the infection. It can also serve as a diagnostic modality, providing specimens for histopathological examination, as well as for microbiologic diagnosis and testing. With regards to diagnosis, characteristically, mucormycosis presents as a hyphae that's broad, 5 to 15 micron diameter, is irregularly branched with rare septations. And furthermore, in addition to histopathological examination, numerous journal articles have cited the use of serum tests such as 1,3-beta-D-glucan assay, as well as the aspergillosis galactomannan assay. Now, with regards to mucormycosis, it does not share these cell wall components, so these characteristic tests will not be positive, rather will be negative. So negative will serve as a positive test in this case. With regards to treatment, recommendations center on antifungal therapy that can ultimately hope to improve outcomes. Now, the gold standard initial therapy is amphotericin B, specifically the lipid formulation, is the drug of choice. Usual starting doses is between 5 to 10 milligrams per kilogram of liposomal amphotericin B. Now, 5 milligrams is a good dose to start. If there is concern for CNS involvement, most guidelines do recommend 10 milligrams per kilogram. They do cite repeatedly that they do not recommend a slowly incremental or a step up of the dosing to the calculated recommended dose, but rather that it be started on day one. If there is evidence of renal toxicity with the use of amphotericin, the dose can then be reduced to 5 milligrams per kilogram per day, but not less than this. Now, given the widespread of cases in some areas, the lipid formulation of amphotericin B might be limited, in which case amphotericin B deoxycholate can be used if there is an issue with availability of the lipid formulation. In this case, they do recommend a 1 to 1.5 milligram per kilogram per day and about 5% dextrose, slowly infused over 6 to 8 hours. Now, this therapy is recommended to be continued until the patient shows signs of improvement, as well as with fluid infusions with normal saline prior to administration, use of additional treatments to prevent drug reactions, as well as monitoring of the renal function and electrolytes. Now, in some cases, patients either do not respond or cannot tolerate amphotericin B due to drug reactions or renal toxicity, in which case salvage therapy with posaconazole and isovuconazole is available. Posaconazole, normally they recommend the IV formulation, but if a patient is able to take the delayed release tablets, these can be used as well. Both recommend 300 milligrams every 12 hours for 2 doses during the first day of treatment, followed by a maintenance dose of about 300 milligrams every 24 hours. Attention should be made to monitor a patient's renal function. In the cases of a creatinine clearance less than 50, most guidelines do recommend avoidance of the IV formulations and transition to the delayed release tablet of posaconazole or isovuconazole formulations. Now, isovuconazole is commonly given as a loading dose, 200 milligrams, either IV or orally every 8 hours for the first 6 doses, followed by 200 milligrams every 24 hours thereafter. Slide, Dr. Prakash. Now, if a patient is able to respond to amphotericin B, then the attention turns to antifungal step-down therapy. Now, this again corresponds to posaconazole. It's delayed release tablet. It's given as loading dose, 300 milligrams Q12 hours on the first day, followed by 300 milligrams following. Now, with the delayed release tablet is recommended, and they do not normally recommend the oral suspension, as it is not, as concern has been raised due to its bioavailability, and if a patient is ill, they may not be able to ingest the large food or fatty meal that is required with absorption. And after about a week of therapy, trough of the drug should be obtained in order to ensure appropriate therapeutic concentration. With regards to isovuconazole, again, it's the loading doses that are required for the first 42 hours in step-down therapy. That's 200 milligrams every 8 hours for 6 doses, then followed by 200 milligrams orally once a day following that. Now, this chart is a nice summary of these recommendations provided by the global guideline for the diagnosis and management of mucormycosis, as provided by the European Confederation of Medical Mycology. And it's a nice summary with regards to treatment of clinically suspected or confirmed cases of mucormycosis. And I did provide this in this slide just as a summary. Next slide, Dr. Prakash. Now, with regards to the length of therapy, most guidelines, unfortunately, did not provide a specific length of treatment, but generally they do recommend that therapy should continue until there's clinical resolution or improvement of signs and symptoms of the infection, as well as resolution of any radiographic signs of the active disease. Therapy should also continue until reversal of the underlying expression can be achieved when feasible. However, this often may extend to months with some patients. For instance, with regards to the studies that are reviewed, the median duration of isovuconazole first-line therapy or salvage therapy was about 84 days of both the intravenous and oral route, as well as the median therapy with regards to posaconazole ranged from either 1 week to 3 years, with the mean duration being about 6 months. However, the lifetime of therapy might be required if a patient's immunosuppression cannot be corrected. Now, I'd like to thank you all for your attention. I'd like to turn the presentation back over to Dr. Sundaresan, and who will lead us through a discussion of some clinical cases.
Great, thank you, Dr. O'Keefe, for that wonderful review. So I want to thank Dr. Muruganathan, who shared some of these cases from India. And I would like to invite all our panelists, especially Dr. Korala, who has been leading the pandemic response in Nepal, and our Commander-in-Chief up until the time that he went to leave us and go back to Nepal. So I would like to invite him to make some comments here as well. I'll start with case 1, which is a 38-year-old male with diagnosis of COVID-19 in May of 2021. He was admitted to a peripheral grassroots hospital and then shifted to a bigger hospital. But when he was admitted, he was treated with remdesivir, he was treated with steroids, and also a monoclonal antibody. He required initially a high-flow nasal cannula, which kept up his saturations, and then non-invasive ventilation. He was awake, he was prone, but his oxygen status worsened, and about 10 days into this presentation, he also started to note right-sided facial swelling. You can see a picture of that. And then the patient was intubated, and a CT of the nasal, paranasal sinuses showed that it was suggestive of sinusitis there. Endoscopy was done, and they did obtain some specimen, which was not very clear cut with the diagnosis. On his labs, he was also noted with thrombocytopenia, and a culture that was done showed gram-positive cocci in his blood, and his respiratory specimen had gram-negative bacilli. So there were these questions to address in terms of what treatment would you give the patient, when would be the right time to do an endoscopy, get an ENT evaluation, get a surgical evaluation, and also in terms of other comorbidities, TB, do we really need to worry about TB in somebody who is presenting with a chest x-ray like that with a cavitary lesion, and also with mucormycosis in general? Is TB a risk factor? And would you just refer this patient to a higher level of care? With those in mind, next slide, please. I would like to open these questions up for discussion. With steroids and COVID-19, is that an independent risk factor, or is there any correlation between the dose of steroid, type of steroid, route of administration? And I'd like to open that up to our panelists and also for discussion and questions with any of our audience today.
And Molly, if we can have our panelists and all of our participants unmuted so that they have the ability to add to the discussion, that would be excellent, because we would love to hear from everybody.
Absolutely, Dr. Prakash. All of the participants feel free to unmute yourselves, and if you aren't able to, just let me know and I'll fix that for you. But you should all have the ability to unmute now. So please join the discussion when you can.
Dr. Corrala, would you like to share your thoughts?
Yeah, sure. Just looking at the question number one, the steroids in COVID-19. Yes, it is. The steroids are risk factors, well-known risk factors for fungal infections, including mucormycosis. That's the question, right? For the mucormycosis, yes. But we don't see, steroids are used so commonly in the clinical practice. So we don't see mucormycosis that commonly with steroids alone. So you always need either, high dose steroids for prolonged duration, or you need something in addition to steroids for mucormycosis. In case of COVID-19, like Dr. Prakash very well described the mechanism or the pathogenesis earlier, there is increased risk from other reasons in addition to steroids. So steroids adds to the insult or the increased risk caused by COVID-19, which was alluded to by Dr. Prakash earlier. So it's the more like synergistic effect of the two leading to the increased number of cases, or more than what is expected for mucormycosis.
Thank you, Dr. Corrala. And a bigger question comes when you make this diagnosis, the importance of stopping the corticosteroids, which you had started for the COVID-19, but that and other immunosuppressive drugs like the IL-6 inhibitors, tocilizumab, the importance of stopping those when a diagnosis of mucor is entertained.
Yeah, thank you. That is something that we typically see with infectious diseases and immunocompromised patients. Sometimes, in addition to treating the infection, you also want to try to minimize the cause or events that as much as possible by decreasing the level of or degree of immunosuppression, whether it's steroids, whether it's diabetic control. So you want to address the independent, the risk factors in addition to the infection as well. And the reason I actually asked this question was that steroids were being used a lot for patients who were also at home. With COVID-19, we've typically seen that steroids really are useful for patients who are with moderate or severe disease and admitted to the hospitals. But a lot of people were using this at home, and steroids actually being available over the counter earlier on in the pandemic was also something that kind of added fuel to fire there. But it's important to understand that in itself is not a risk factor. There's something in addition to that we would like to also look at when these patients are admitted, and undiagnosed diabetes and tuberculosis actually is also listed as a risk factor. So like the patient who had that cavitary lesion on chest X-ray, in fact, ended up having a gene expert which was positive for MTB as well. So those are some of the other things that should be looked at.
And Dr. Sundaresan and Dr. Corrala, I would love to hear your thoughts on this. It's a balancing act, isn't it? Because you're treating the COVID-19 with the steroids and the IL-6 inhibitors. Now you're having to take it away. So in essence, you may be compromising treatment for one infection to treat the other one. What a fine balancing act that is. Can you comment on that? I would love to hear, your comments and from your experience.
So I can make a small comment on this. The use of steroids is like, a kind of catch-22 situation. because the recovery trial showed 6 milligrams of dexamethasone, which is a small dose, which is our moderate dose. It's not a big dose. If you convert it into prednisolone, that's 30 milligrams, or if it's methylprednisolone, that's 24 milligrams, so which is moderate dose. It's not high dose like 60 or 100 milligrams. So, and that too, they very carefully used it for 10 days. But what's happening is, there have been use of steroids at a higher dose, first of all, and then for a prolonged duration, which is not quite yet supported by the studies. Maybe in some cases, there might be benefit. For example, if somebody has ongoing inflammation, fibrotic changes, so in those selected cases, steroids might need to be used for longer duration than 10 days. But there are studies, not quite, controlled clinical, the controlled or RCT, randomized control trial, not quite there. But whatever data we have seen shows that steroids, if they are used for prolonged duration, meaning beyond 10 days, they do have some benefit in terms of respiratory status, meaning they will have better oxygenation. But on the other hand, if you look at their 28 days mortality rate, they actually end up dying more. So there is a higher mortality with prolonged course of steroids. So that's why you have to be really careful and use high dose and prolonged dose of steroids in only selected patients where it's indicated.
I don't know how much time we have, but I would like to at least take one other question on this slide, which is amphotericin B. We use a pre-treatment regimen, and those specifically target some of the side effects. And I would like to put Dr. O'Keefe on the spot and see if you would be able to answer these questions for us about what we do for pre-treatment with amphotericin B, and also if you could discuss some of the side effects, please.
Thank you, Doctor. Now, with regards to the amphotericin B, most common side effect is what's best be described as infusion-related side effects. After the administration, patients can develop fevers, they can develop chills, they can develop nausea and vomiting, and there can also be concern for pain, swelling at the infusion site, which can ultimately lead to thrombophlebitis. Now, with regards to the resources that I reviewed, there are pre-treatment regimens that are recommended, such as more often than not, there's concerns for renal toxicity. So commonly, if able, a normal saline infusion is given prior to the amphotericin B infusion to help with hydration. Tylenol can be provided with regards to the prevention of this reactive fever and chills, as well as Benadryl as well. With regards to lab monitoring, the primary area of concern with amphotericin B would be unfortunately, the kidneys. So monitoring for renal nephrotoxicity, such as worsening of the renal function, electrolyte abnormalities, specifically of the potassium and the magnesium, that can be corrected if able. That is with the primary that's the primary cause of concern with amphotericin B. Now, it does have its primary area of concern with regards to the kidneys. However, the alternate therapy for salvage and step down, such as posaconazole and isobuconazole, is not without its own faults, specifically with regards to hepatotoxicity, and that could be just monitoring of the kidneys. That's my 5 cents with regards to the discussion, but please, Dr. Sundaresh, Dr. Prakash, if you have any other information, please feel free.
That was more than 5 cents. Thank you, Dr. O'Keefe, for that complete answer. And yeah, I think the only thing that I would like to add is electrolytes of a magnesium level should also be added to that, because you do see hypokalemia and hypomagnesemia can be easily corrected. So that would be another thing to add. We typically look at these as shakes and bakes when people are given the amphotericin infusion either too fast, or you want to decrease the side effects and you give it for a very long time. Both those can be inconvenient for the patients. So we typically give the side effects, the infusion over about 4 hours to make sure the side effects are kind of balanced, not for too long and not very profound either. So about 4 hours or so. And we try to use the lipid complex, or which is very popular here, to minimize the side effects. So, and most of them are described as shakes and bakes. Bakes meaning fever, shakes means just a lot of chills that the patients can experience. So pre-treatment definitely helps with that.
Dr. Sundaration, we're at 10 o'clock. I would like to ask Dr. Brahani, is it okay to go over? If you would like for us to wrap up, I would like to end with Dr. Kerala sharing his perspective on the situation in Nepal.
Hi, this is Ankur Barija, the faculty here on behalf of Bhavya. Thanks a lot, everyone. Thanks, Dr. Prakash. It's okay, yes, to go over a few minutes if it's okay with you all. And we really, really appreciate your time and would certainly love any thoughts Dr. Kerala has to add. So yes, we're okay with that. Thank you.
Thank you so much. And we will make the slides available. Dr. Kerala, would you like to talk about your experience and your take on the situation in Nepal?
Sure. Yes. It's we heard the news in India. It's a huge outbreak. There are, multi-state huge outbreaks in India, as Dr. Sundaration described earlier. So we are alarmed by that, thinking that what's going on in India, because being a free border and people moving across the border and things shared, a lot of things shared between the two countries, we thought maybe there's something that was not right that was causing the problem. As we know, mucormycosis is not like COVID-19. People were really worried, especially the news media was alarmed. They were saying that now it's in India, it's going to come to Nepal. It's like, a next pandemic or next epidemic. So we had to do a lot of educative programs to tell people that it's not something like COVID-19, it's different. So it comes from environment. But what we were worried about was, is it contaminated oxygen tanks? Because this happened right at the time when there was a shortage of oxygen. So the oxygen supply, because of the shortage of oxygen supply, in a lot of places they were using these oxygen tanks, which are used in actually industries for furnaces for high temperature, industries requiring high temperature, such as for iron or steel or other kind of metal industries. So these are not hygienic or hygienically maintained like in the hospital. So we are worried that maybe that's where the contamination is, or maybe the oxygen supply is contaminated, something like that. So we saw about 6 cases in the beginning in the southern part of Nepal and in a couple of other places. But as far as I know, it's a little bit old data. I saw it was a couple of weeks ago. There were only 11 cases in the whole country, including a couple of cases reported in Kathmandu, and then and then a couple of places. There are only 10 or 11 cases, which is not a big number and which is not out of ordinary for the size of the country with population of close to 30 million population. So this is like, just the usual. And then they are seen in diabetic patients. One of the main difference between India and Nepal is that they don't use that much of IL-6 inhibitors in Nepal. I'm sure that they use a lot more in India and US. So maybe that's why we didn't see that many cases. And these were all, as you all described, primarily in the nasal sinus, compartments. And then there's also a shortage of amphotericin B because I think they were using a lot of amphotericin B in India. So the people in Nepal were worried that we may not be able to procure even amphotericin B because of the shortage in the market, because we share the same drug companies between the two countries. So I haven't heard anything in over the last couple of weeks. The government and the Nepalese CDC, which is known as EDCD, also had a lot of educational programs and media campaign telling people what to do, including taking precautions for oxygen, cleaning the humidifiers, changing the nasal cannula and things like that. And hospitals also took appropriate infection control measures. So fortunately, we haven't seen too many cases here in Nepal. And I did not get to see a patient except one case I just saw today, because we're going to have this webinar. This morning, I saw a case with pulmonary cavitary lesion, and they consulted me thinking that could be mucormycosis, but I believe it is just a case of, it's a COVID case who has been, I think it was a month ago, and she was diagnosed with COVID, and her condition is not improving. But what it looks like in her lungs is cavitary pneumonia or some kind of abscess in the lungs. So, right.
Thank you so much, Dr. Kerala. And many thanks to the Health for the World team. Thank you to Molly, Dr. Rahani, Dr. Badija, and many thanks to you, Dr. Kerala, Dr. Sundaresan, and Dr. O'Keefe for this team effort. It's truly an honor to be a part of this team and the Health for the World team. And thank you all for joining us today. I don't know if there's still time to continue with the chat and answer questions, or if we have to close.
I think at this time, I'll, on behalf of Health for the World, I'll say we'll wrap up. And thanks a lot, Dr. Prakash, Dr. Kerala, and Dr. Sundaresan, and Dr. O'Keefe for your time, excellent insights. This is all recorded and will be uploaded and available to anyone, anywhere. We'll share the links, so feel free to disseminate to your networks. And let's see, do we have people joining in from not just India, Nepal, but other parts of the world as well. So, and are received some great remarks. And sounds like it's been very useful discussion. So on that note, I see Dr. Sanjeev Thakur joining in from Nepal, talking about sharing. Were there any comments, Dr. Thakur, that you wanted? I see that you had raised your hand.
Yeah. Hello. Am I audible?
Yes, you are, sir.
Yes. Yeah, so I saw the presentation. It was really very informative, and I just saw the remarks by Dr. Janak Koirala, and so I also felt like sharing my experience that I have managed 2 cases here in Nobel Medical College in Viratnagar, Nepal, and I'm from ENT faculty, and so we have managed 2 cases of this rhino ocular surgery. One was managed endoscopically, and in one we had to do inferior palatectomy with the resection of the skin involved in the right maxillary, over the right maxillary sinus. And the first patient was very limited. It was a lady, a diabetic, and she is fine. We have discharged her 2 weeks back. And this week we are managing this gentleman who is a diabetic, and both this diabetic person, he had not suffered from COVID. So what we are, I just wanted to make point is that maybe he did not get tested for COVID, or I think we are seeing some mucor even in non-COVID patients also. And I think this point was raised by few doctors from India also. So I just felt like sharing this, my opinion, and my observation, my experience.
Thanks, Dr. Thakur, for sharing and joining. Any comments from our panelists on that? Okay, so well, thanks again. We really appreciate your time, and thanks all the audience for joining and the participation. As I said, this is all recorded and will be available online. Thank you all for joining. Have a nice day.
Thank you.
Thank you, everyone.
Bye-bye.
Take care.
Thank you. Good to see you all.